This lecture is related to peritonsillar abscesses. Peritonsillar abscesses are an accumulation of pus within the peritonsillar tissue between the tonsil and the pharyngeal constrictor muscle. They're common, deep infections of the head and neck. The abscess frequently occurs in a patient with a history of recurrent chronic or improperly treated tonsillitis. And from the epidemiologic standpoint, we generally see prevalence between middle teenage through age 40. 1 in 6,500 people in the United States will experience a peritonsillar abscess. And so that's prevalence is between 9 and 22%. And the risk of reoccurrence is greater in younger than 30-year-olds or smokers. The pathogenesis is often related to inadequate treatment of tonsillitis, and the actual mechanism is a blocked Weber glands. It progresses to cellulitis, then pus formation that occurs in the peritonsillar tissue. So how do these patients clinically present? They are usually toxic, okay? They have fever, chills, fatigue, malaise, foul breath, dysphagia, severe sore throat, and otalgia or ear pain. The patients look ill. They report pain radiating to the ear on that affected size. Trismus is often noted in these patients, and drooling is typical, like they can't, it's so uncomfortable to swallow that they can't control their saliva. And then a lot of times we'll hear the hot potato voice, and you'll hear that in strep too, where I hold her, I got hot potato in my throat. All right. And I don't know how that comes over on video, but just think when you have had actually put something hot in your mouth and before you can spit it out, how that feels. And the mechanism of that is it hurts to move. So if you hold that whole anatomy still, it's less painful. And we call that the hot potato voice. So what are we going to find on physical exam? We're going to see marked edema, erythema of the peritonsillar tissue and the soft palate. The tissue is often fluctuant and it's covered with exudate. It's almost always unilateral. In my 25 years of practice, I've never seen it bilateral. Now, it can be confusing when that tonsil is so large that it covers the entire space, like it looks like 2 + 4 tonsils, but it's only 1 + 4. Tonsils are displaced downward and medially. The uvula is often edematous and displaced to the opposite side. Trismus, tender cervical adenopathy, tachycardia, pooling of saliva or drooling, and signs of dehydration can be present. Diagnostically, peritonsillar abscesses are easily diagnosed on the basis of physical findings. Once you have them, open their mouth and you look at that tonsil. So what's management? Surgical intervention is required, okay? And it's usually with needle aspiration, I&D, or a tonsillectomy. I think the majority of peritonsillar abscesses can be treated successfully and effectively with needle aspiration, antibiotics, pain meds, and hydration. Tonsillectomy may be required, but it's usually what I just said. Referrals, after diagnosis, it's an immediate referral to an otolaryngologist, and they will, I've never had an otolaryngologist decline to take my patient with a peritonsillar abscess. Education and health promotion. So you've got to educate the patient and the family that peritonsillar abscess can be a complication of tonsillitis, so they're looking ahead. It can reoccur. Signs and symptoms are described to patient and family, and we also need to really educate on the side effects of antibiotics and the need for completion of antibiotics. Recurrent tonsillitis is a risk factor, poor oral hygiene, and smokers also. So that's got to go into that health promotion, disease prevention. And you need to include, after the acute phase, oral health and smoking cessation education. Thank you.